Hi, everyone. Good afternoon. Thank you so much for joining us for the Tourette Association's virtual conference. We apologize for the delay. Our keynote ran over by a couple of minutes. My name is Chelsea Tolner. I'm the Director of Outreach and Education at the Tourette Association of America. Thank you so much for joining us today for the Tourettic OCD Exploring the Tourette and OCD Interface session. We want to quickly thank our platinum sponsors, the Warner Fund and Pharma, as well as all of our donors and supporters for making this free conference possible. To support other educational programming like this, you can visit tourette.org/donate to make a contribution today. During the session, we would love to hear from you to include your voice in the conversation. You can ask questions or share comments using the questions panel on the right side of your GoToWebinar player. We will collect questions and address them for a couple of minutes at the end, but there is a lot of content today, so any questions we are unable to get to, we will gather them and we can either follow up with you afterwards, or you can also reach out to support@tourette.org and we can follow up with you there as well. It is now my pleasure to introduce our presenter, Dr. Charles Mansueto. Dr. Mansueto is the founder and director of the Behavior Therapy Center of Greater Washington, a leading center for the treatment of obsessive compulsive and related disorders. He received his doctorate from Catholic University and completed his postdoctoral clinical training at Temple University School of Medicine. He has over 35 years of experience in the application of behavior therapy to a broad range of clinical problems. Dr. Mansueto has written extensively and presented nationally and internationally on OCD and related disorders. He currently serves as a member of the Scientific and Clinical Advisory Board of the International Obsessive Compulsive Disorder Foundation and chair of the OCD Mid-Atlantic, an IOCDF affiliate. He is past president and now serves on the Scientific Advisory Board of the TLC Foundation for BFRBSs, hair pulling and skin picking disorders. He is a past member of the Medical Advisory Board of the Tourette Association of Greater Washington. He retired as a tenured professor of psychology after 36 years in the University System of Maryland. Thank you so much for being here today, Dr. Mansueto. You can now go ahead with your presentation.
Thank you. Okay, I'm going to get my face out of the way so I can see, and I'm just assuming that everybody now can see my presentation. So we're going to start today, as you see, the heading, Tourettic OCD, Exploring the OCD Tourette Interface, and we'll go right now. And I have a lot to present, so I'm going to move kind of quickly. If anybody, well, I don't know if you can reach me, but I'll try to speak clearly, but quickly so we can cover all of the information. Also, if you have questions, we may not have much time at the end, starting late, and because I do have a lot to cover, then you can contact me in other ways and I will get back to you. Okay, let's see, how do we, now it's not moving, so let me just see what's going on here. Oh boy, all right, here we go. All right, I'm going to remind you that by the way, many of the times that I present this and similar material, I'm speaking to an OCD population mainly, that is professionals who treat OCD and have interest in Tourette's. This, I understand, is probably the converse, that more people are knowledgeable perhaps about Tourette disorder and less so about OCD. But what I want to make, the point I want to make is that OCD is based on anxiety models, our understanding. That our ordinary way of treating it is based on an anxiety reduction model. It relies on habituation of anxiety, the idea that if we have unnecessary anxiety for any particular cue or circumstance, that with repeated exposure to that, we should be able to experience a reduction in that anxiety. That's the behavioral technique mainly, and it's called exposure. And in OCD, we call it exposure with and response prevention, meaning keeping the person from avoiding or escaping from those experiences, but waiting until the process of habituation occurs. Cognitive techniques, another empirically supported approach for treating OCD, are designed to correct any misconceptions or distortions about the nature of what is happening. So if a person really believes that they can get AIDS from a doorknob, then that information would be provided for them. Also, there are experiences that are provided called behavioral experiments that allow a person to realize that they can tolerate and live through experiences that prior had produced a great deal of anxiety. So one way or another, again, the notion is anxiety reduction at the basis of the treatment. Today, looking at it from the OCD side, we're looking at it, what if at this particular point, what if the driving force is not anxiety, but some other aversive experience that fuels OC functioning? In other words, if what's driving a person is not truly fear, but we're going to be looking at discomfort, somatic discomfort or central discomfort, but not necessarily anxiety, not the idea that there is danger out there that may in one way or another affect my well-being. So we're looking at that notion, sensory discomfort, as a basis for non-anxiety based OCD. By the way, there are other areas that I'm interested in exploring a bit further that are also non-anxiety based. Some OCD is based upon disgust, not exactly anxiety, and another form might be based on shame or guilt, but they're relatively minor compared with those that are anxiety based. But sensory discomfort, I will argue today, is not so uncommon, and that it has a unique presentation that perhaps suggests that it's closer to Tourette's than we ordinarily construe it to be. So there are two major points in today's presentation. One is that OCD and Tourette's are more closely related and more commonly interactive than is commonly appreciated, perhaps from both sides of the board. And secondly, it matters in these ways, that the position here is that taking into account these particular characteristics of what I'm calling Tourettic OCD is looking at the possibility of developing more effective treatments. So we'll look at that, and that's very important, of course. If there's a subcategory of OCD or a type of Tourette's presentation, a manifestation that matches this, that we might be able to get more effective for treating this merged condition. And second, from the OCD side, perhaps again, the alphabet soup kids, a term that I've given, and I don't think it's unique, but to kids who have a complex of a number of associated conditions. In the Tourette's world, it's sometimes called Tourette's plus or tics plus, the other kinds of comorbidity that often accompanies the presence of overt tics. There are a couple of other implications that we'll explore briefly today that we might better understand and possibly prevent an evolutionary form of OCD occurring. That is, we'll look at the possibility that Tourette underpinnings can evolve into OCD. Now, why that's important, as we'll see, and as you may be aware, Tourette does seem to abate in the majority of cases as a person matures beyond puberty. Not so with OCD. OCD seems to move very effectively through puberty into an adult form. So if we can prevent this form prior, we might be then preventing OCD from becoming a lifelong affliction. So the idea of prevention is very interesting and exciting to me, since that's not something we usually discuss with within these categories. We'll also look at the other possibility, a much more less common possibility, that OCD can also evolve into tics, and we'll just look at that because that's something that I've become aware of, that possibility, since I did some of the writings. If you've seen any of the writings I've done on Tourettic OCD, then it's not contained in those writings. And finally, this is a way of integrating disorders that are quite commonly together in some way. So, and this is indicating that perhaps they're two sides of the same coin, and that will aid in the other possibilities that I just mentioned. So again, I mentioned before that often this presentation is more to an OCD audience, so there'll be a little more on tics that I will bypass. Most people are more familiar, most clinicians are more familiar with OCD than they are with tics, unless you're in the tic world. So I'm going to skip quickly through some of the things that focus on the presence or absence of tics. But as we know, the traditional view of OCD is that it's based upon obsessions. These are intrusive and unwanted ideas, usually accompanied by distress, anxiety, fear, and it results in rituals, compulsions that are designed to either, to both usually, reduce anxiety and also the possibility of the feared outcome. So if I'm getting treatment, exposure and response prevention treatment for the fear of getting AIDS from a doorknob, I'll likely be exposed to contact with that doorknob or things that have contacted it, and with the assumption that over time I'll become less anxious, and also the idea that I will get tics will become more less salient, less important to me. And here I won't go into the difference between tics and Tourette's disorder. All of that should be very familiar to you. Also, the categories of tics. Again, they're modified a bit from DSM-4 to DSM-5, but they are very familiar over the years to those who have explored tics or work with them or experienced tics. So these are the categories of tic disorders. Now, why I'll go back over this, even though it's familiar, is because we're going to take another look at this from the standpoint of typical experiences with OCD and specifically with Tourettic OCD. But I'm going to remind you that these will become important as we look to the notion of TOCD. That tics typically began 6, 7 or so, a little bit earlier with boys and girls perhaps, peaking during early adolescence, and then waxing and waning. By adulthood, the statistics vary to some extent, but generally it's not too far off, I suppose, to say that in 75% of the cases, they're abated a bit, they're no longer considered much of a problem, or they're actually gone. 15% continue to have moderate problems with tics and 10% severe problems. And of course, we don't know which it's going to be for any individual, but these are the probabilities, that the probability being that tic disorders will, in 75% of the cases, abate and become less of a problem. And another reminder is that tics are not uncommon, that they occur in the general population of children, perhaps as many as 1 in 5 having tics of some sort during the course of their development. Now, the associated traits, again, this audience very familiar with them, but I'll just mention these are the kinds of tic disorders that come with Tourette's plus. The associated traits that come with tic disorders and Tourette's plus. Commonly inattention, impulsivity, often resulting in a ADHD diagnosis, disinhibition of various sorts, behavioral, emotional disinhibition, looking like meltdowns, sometimes anger outbursts, often leading to another label of oppositionality or emotional dysregulation. The hyper restlessness, learning disabilities, and you go down the line, sensory processing problems, BFRBs. If you're not familiar with that term, it's not a diagnostic term, but it is an encompassing term, body-focused repetitive behaviors. And the most common forms are skin picking and hair pulling. And often we see kids with their arms and legs, the mosquito bites that have now turned into bloody messes and scabs being picked and so forth. And when is a great combination of these associated traits, I would typically call these the alphabet soup syndrome, indicating that kids, if they see a number of therapists who make different diagnoses based upon the presentation, they may get a smattering of varieties of labels attached to them, which can make parents throw their arms up and think, how many doctors do I need to see? How many problems does this kid have? How many different medications will he need? All of these things, the kind of confusion sometimes, often, and concern associated with multiple comorbidity that here is called the alphabet soup syndrome. Now, the origins of this, when I worked at Temple, I went there originally to study with Joseph Wolpe, who was once called the father of behavior therapy. He's not quite so popular anymore. We remember him for a systematic desensitization, perhaps, that treatment that isn't widely used. Exposure has dominated as a anxiety reduction approach. But they asked me to stay on. I founded and ran for 5 years a child and adolescent component of the Behavior Therapy Institute program. They only treated adults up to that point. And so I got lots of kids with OCD under 16 and under came into my program. Older than that went into Edna Foa's program. Many of you who work with OCD or know about OCD know of Edna Foa. She did a lot of the seminal research that allows us to understand and treat OCD effectively over the years. But I had just really hundreds of kids coming into the program, many with tics, Tourette disorder alone, others with OCD, and lots of them with both. So I began to look and draw connections between the tics and the compulsions, and that's what evolved into my thinking about Tourettic OCD. Did I skip a, no. Okay, so what is the origins of this? Not only seeing the connections between the two, but beginning to try to comprehend them more effectively conceptually, how to conceptualize what I was seeing with my OCD, Tourette's kids, and tic kids, and the ones who had combinations. I began to explore modifying treatment for patients who seemed to have characteristics of both, and these were the TOCD sufferers. Eventually, it seemed to help me understand better and communicate better with the families and the individuals in this camp, and my colleagues also were interested in it, and I began to teach them about it. Finally, someone said this needs to be published, and I said, well, I have no data, and it's very hard to get a theoretical paper published these days without any empirical support. But it did get published, and then we could see how it flew. In other words, how would other members of the professional community construe it? And the first paper was in 2005. My colleague Dave Kuehler and I published this tic or compulsion. And this was a very common question that would come up. Is this a tic or is it a compulsion? And my answer was it's Tourettic OCD. And let me give you some ways of thinking about this a little more specifically, tangibly. I would ask people in the audience, and you can play with this a little bit too, but I've revealed my cards to some extent. But I ask people to just quickly write down either a T or an O if this is a tic or this is a compulsion, I'm sorry, a compulsion, T or a C, and here are the 10 items. Evening things up, tic or compulsion. Walking in and out of doorways, tic or compulsion. Doing things symmetrically, for example, from side to side. Touching things over here, make me having to touch, needing to touch things over there. Switching things on and off, even though it's unnecessary. Smelling things. Tapping surfaces or other people, but tapping one's own body. Repeating actions to certain numbers. In other words, when one should do it, maybe having to do it to a certain number. Walking in patterns. Spitting excessively. Counting things unnecessarily. Okay, well, if you played along with me, then you might have anticipated that it's not so easy, and maybe it's even impossible to determine whether these are tics or compulsions. And think about what you would want to know in addition to just the overt manifestation that would allow you to answer that more conclusively. Or another possibility, what if they are both? What if they have characteristics of both, and therefore we're not dealing with a categorical phenomena, neither fish nor fowl, That's the idea here. So whether it would fly, whether the professional community would welcome it. Well, it was republished. This is the exact same article, republished in Focus, a journal of lifelong learning in psychiatry. So originally it was in a psychology journal, republished in a journal that proposed to publish seminal and influential articles. And it was among the 10 most requested articles for almost a decade following it. So it flew. And that was very exciting and interesting to think that this idea was worthwhile and might be better spread than kept in-house. Finally, this is a better article I wrote, which was really for the OCD newsletter. It was not published that's a semi-professional forum because everybody in OCD gets this newsletter. And a lot of times ideas are floated there, newer ideas that are among both the suffering, those who experience OCD, and also the professionals who are interested in it. There, many of the ideas that I'm presenting today were first proposed as adding on to the TOCD conceptualization. So first, now here, do they deserve to be really different disorders? And when are they not different disorders? All right, and DSM-4, they were clearly in two different chapters: anxiety disorders, OCD, disorders first diagnosed in infancy, childhood, or adolescence for tics and Tourette's. In DSM-5, they moved a little closer together. OCD and related disorders is where OCD obviously falls, and that's where, but still other developmental disorders is where the tic cluster is. However, there's tic-related OCD in DSM-5, and that, I would say here, is not identical with Tourettic OCD. That requires the presence of tics in conjunction with OCD features. TOCD doesn't. The assumption is that there's an underlying Tourettic nervous system, and it doesn't necessarily manifest as overt tics. Other differences between OCD and Tourette's, what we call them, the outcome, the often overt second part of the problem is called compulsions in OCD and tics in the Tourette's world. The instigating features are called obsessions with OCD and premonitory sensations, again, among tics. Clinical characteristics. We usually, very often, think of a difference here between OCD and tics. Tics are thought, OCD is thought of as willful and goal-oriented. I'm trying to watch, I'm trying to check and make sure that no harm will come to my children. I want to just make sure that I haven't injured someone else, and so on and so forth. So repetitive behaviors are willful, goal-oriented. They're understandable. You may not agree with why I'm doing it, but you understand what I'm up to. Whereas tics seem less rational, more involuntary, not under control, and not always, and more nonsensical, perhaps, not necessarily relevant to whatever preceded it. The course, with OCD, we expect it to be relatively constant, with perhaps onset from childhood, but it can start in adulthood just as easily. It's a chronic disorder, and whereas with Tourette's, we have typically, as we said before, the childhood onset, the adolescent worsening, and adult abatement. So the course can be distinguished one from another. And finally, with OCD, although the most common comorbid condition is depression, and we don't necessarily expect to see a whole array of coexisting conditions, but significant comorbidity does seem to be the case with Tourette's and tic disorders. Now, this is important too, the distinctions between treatment approaches. It's quite clear in OCD. There are two empirically supported treatments. In CBT, what's called the hallmark treatment, the treatment of choice, exposure and response prevention, and cognitive therapy having also some empirical support. So combinations sometimes are the our appropriate treatment. With medications, clearly as SSRIs are used as a first choice of treatment. Various augmenters may be used in association with side effects, to reduce side effects or to help with some comorbid features and so forth, but very clear. Now with tics, though, and Tourette's, Tourette disorder, we have CBT, contingency management, relaxation training, the idea being that arousal does exacerbate often tic conditions, habit reversal, I guess you might say the treatment of choice, and CBIT, comprehensive behavioral intervention with tics, is basically habit reversal with a few minor adjustments. So Azrin, who created habit reversal in 1970, or reported it in 1973, would recognize it quite easily as a habit reversal approach. The medication, previously and currently, the use of neuroleptics. Prior, the typicals, the older school neuroleptics, and the atypicals more currently, but still neuroleptics are considered appropriate choices. And the alpha-2 agonists, the clonidine and guanfacine, being the two medications that operate in different ways, often are now more widely used because of concern about possible unwanted side effects of the neuroleptics. They are powerful medications in developing nervous systems. But what about the relatedness? Those would emphasizing distinctions between the two. Well, it's quite clear that there is a frequent comorbidity between the two. I've seen statistics that's probably in the ballpark that 30% of people with OCD have had tics in their past. Kids, 30% may currently have tics. In the case of tic disorders, maybe 50%. Higher amounts have OCD features, and therefore the comorbidity is quite notable. Those who look at genetic linkage found, looking among the family tree of persons with either tic disorders on the one hand or OCD on the other, will find the presence of the other disorder more than chance alone. Again, suggesting there might be some genetic linkage that, and this would lead to possible shared neurobiology. While these are being sorted out, there are some distinctions that have been noted in the literature. There are enough similarities to say that we aren't dealing with tremendously different kinds of phenomena. And finally, what we've already begun to explore here, the idea of similar clinical presentations. Okay, I hope everybody's with me. Okay, so now Tourettic OCD. What are the distinguishing features? And we're going to try to now pin down a cluster, a familiar, recognizable set of characteristics that would allow us to distinguish the Tourettic OCD individuals from what I call the classic or pure OCD. Forget the second one. Pure OCD is a term it's been jumbled up by a lot of things. So just say classic OCD on the one hand and classic tics on the other hand, classic Tourette's disorder on the other hand. Okay, so now we're looking at the possibility of a central merged condition, one with characteristics from both sides. First, a report of somatic discomfort, a sensory phenomenon. Being of Italian descent, there's a word in Italian, agita. Well, it gives me agita. Somebody gives me agita. It's not anxiety. Then I'm not afraid of them. I'm not vigilantly worried about what they'll do to me. They just make me uncomfortable. A sensory phenomenon. It's I liken it sometimes if we were at a cocktail party and someone had a piece of broccoli in their teeth and they're talking to us, and we look at that broccoli and get squirmy and really wishing that it wasn't there. And oh, okay, we're not really. It's not anxiety. It's something discomfort. We feel that squirminess, a sensory thing going on. and it has and something's driving us, for example, to try and escape from that, to say, well, excuse me, you know, or maybe even a mention it, say, oh, you know, you have a little something there, something that tries to get rid of this discomfort and so forth. So second, within the Tourettic OCD world, an absence of elaborated obsessions. In other words, it's not that I might touch something and get something on me, a disinfectant that may affect me differently than other people. It may get into my pores, poison me, and I could get very ill or even die. Insect spray, whatever it is. These are ideas, or there's a piece of glass in the road. If I don't pick it up, somebody could fall on it, it'd be my fault, or a thump in the road, it might have been a body, I might have to go back, or I could be arrested for hit and run. That would be awful, go to jail. And so these are not the kind of things that people report when they report this discomfort, this kind of Tourettic discomfort. But they may have an idea that it won't go away though. It won't go away unless I do it. I might as well do it now, because if I leave, I'll have to come back and finish up what I should have done before. And it seems so easy sometimes to just do something, maybe repeat an action until it feels right, or even something up until it feels right. And that's what the compulsion, the so-called compulsions, we'll put them in a quotation marks, because they have elements of tics in them as well, that they involve just right or just so requirements. You'll notice that if you look at OCD criteria and descriptions of the common forms, tacked on at the end is a just right form. And this is the one I think is very close to Tourettic OCD. And most people will report that it seems tacked on. The other ones they get, you know, but this one, the just right stuff, symmetry, tapping, touching, things, touching, retouching, all of that seems a bit different, and it's often the fifth, the sixth of the presenting types of OCD. So we see an emphasis on symmetry. If I touch the left elbow, my elbow to the left arm of the chair, I have to touch it to the right arm of the chair. If I put something down and it didn't go down just all at once, I may not felt like I have to do it until just one click. I don't want to hear a rumbling click when I put something down. I turned something off and it didn't feel quite right. I know it's off. I look it up. There's not fooling me. It's not, but I do it because until I get that feeling that it's just right. Much like a tic that has, you can't get rid of an eye tic by wiggling your toes. You need to do just the right thing, just the right tic to solve that problem, which is behind the eyes, for example, for blinking tic, or perhaps in the jaw for a stretching tic, or just a general sense that if someone touches me, I have that agita, I have to touch them back, and then I feel like it's complete. And you can think of many other examples of this. The idea being that it's that discomfort, that premonitory discomfort, satisfied by almost by a certain fitting behavior that must be done in order to solve it. And if it's not just right, I might have to do it again until I solve it, just like a repetition of tics, until I clear that premonitory urge, at least temporarily. And finally, unlike tic-related OCD and in DSM-5, a person doesn't have to have any tics or even a family history of tics. Anyway, that's hard to get. Usually the information is incomplete and very vague and fuzzy, but it's based upon the presentation, not on the case history or the family history. So what early suggestions may be that that indicate a nervous system prone to this particular form of OCD, Tourette's, TOCD. One is an early sensory processing issue. So when I see this presentation, and by the way, we're known as the Mid-Atlantic Center for Treatment of OCD at the Behavior Therapy Center, and we're in the Washington, D.C. area. So we have I guess, a national reputation for treating that. And so most often people will come to us with OCD more often than purely for tics, although that's changing with our involvement with tics. So I'll ask people, was he tough to dress, perhaps, easy to arouse, hard to settle compared with your other child? Was fussy about eating? And they'll say, "Are you a mind reader? How did you know that?" And they say, "Well, because there's something about his presentation seems familiar to me, and often I see these things in children." So already noting a sort of a hair trigger, easy to arouse, hard to settle nervous system. Easy to arouse meaning excitatory, things come out. Hard to settle, hard to inhibit these things. A personal or family history of chronic or phonic, motor or phonic tics may be there, or even Tourette disorder may be there, but not necessarily and not essentially. Those of you who are familiar with PANDAS, pediatric autoimmune or psychiatric disorder associated with strep, or the more current, the newer version, pediatric acute onset neuropsychiatric syndrome, know that there's some notion that tics and OCD can arise from infections that occur. And first identified by Susan Sweeto at right here. She's a colleague of mine. She's now just retired this past year. Wonderful person. She was the one who came up with the idea of PANDAS, pediatric autoimmune, and the last S in there is associated with streptococcal infections. And now the thought is that it's not just strep, but it can be Lyme and perhaps other more common forms of flu that produce these hallmark symptoms of OCD and tics. Plus an array of other associated conditions like hyperactivity, learning disabilities, sensory dysfunctions, and so forth. So that's another possibility that we've seen, and we treat a lot of PANDAS kids and PANS kids. So the other possibility again being that the TOCD outcome will be related. So sometimes a TOCD outcome, do a few more questions, and it's worthwhile referring these kids for screening for possibility of some medical intervention using antibiotics and other kinds of interventions that it found to be useful for PANS and PANS sufferers. Again, the historical indicated multiple comorbid diagnoses. So it's like you're putting the pieces together. And there's another piece that fits here that they've always had, some people, some professionals might have said, well, there's a, problem with ADHD or some emotional regulation or learning disabilities. They seem to be having some trouble with reading or handwriting. So that would be another thing to sort of a possible historical indicator. If they've been treated, then non or weak response to an SSRI. So if they're an OCD kid and they get SSRI monotherapy, they might not have responded so well. And weak or anomalous response to standard CBT. So again, this often I find myself speaking more to the OCD audiences and telling them at times that there's not something terribly wrong. It may be that these particular standard medication approaches won't necessarily work so well. Or on the other hand, anomalous response. We've seen cases where standard ERP, the thing just disappeared quickly. And we're saying that there was no habituation here. What happened? Why does this work so quickly? And then it may pop up back again as if we never did it. So an anomalous response may be reacting too quickly to CBT, not the typical habituation curve we would anticipate. So what are the treatment implications? How might we think of, just checking my time here, and we go to, we're doing all right on time. The treatment implications. So the idea now is if we're dealing with something that appears to have characteristics of two different disorders, often treated quite separately, what happens if we combine our tools into, in other words, take tools from both toolboxes and consider them for use for this one person in front of me who we think may match this TOCD formulation? So how do we augment it with, again, with if it's OCD or tics or whatever, it'll make more sense with tics, remember, because it's the OCD people. One of the interesting things, by the way, as an aside to all of this, is that I found that by the same kids, when they saw neurologists in our area, neurologists would tend to say that this child has complex tics. But if they saw a psychiatrist or a psychologist, social worker, uh, counselor who is more familiar with anxiety disorders and OCD, then they would say these are compulsions. So again, I've been at meetings actually where it was argued, is this a tic or is this a compulsion? You know, and the idea being we ought to know because it's going to affect the way we treat it. Well, here we're saying no, it doesn't necessarily affect the way you treat it. You just bring in elements from both therapeutic approaches. So a lot more rote practice, perhaps. And so just because a behavior isn't done, like walking up and down the steps with 2 feet on one landing, or skipping every other step or something, then it not just enough just to not do it, like you'd expect. All right, they're not doing it. So if it's a compulsion, they don't seem to have any driving anxiety making them do it. No, if it's tic-like, we want to continue with lots of practice. So more practice, use of contingency management to reinforce practice, since much of this is done self-management. In self-management terms, kids aren't that good at it. So we're trying to reinforce them and get them to practice this as much as possible in circumstances. Substitution strategies. HRT is one substitution strategy. There, a motor habit is practice that's supposed to be competitive. The well-known one is grasping, making a fist instead of doing something else, that like a tic, or pushing the shoulders down. But substituting means to tell the person just don't not do it. That's an exposure response prevention tactic. But to do something else instead, again, drawn from the TIC toolbox, but incorporated into persons who maybe have been construed as suffering from OCD, but we've identified as Tourettic OCD sufferers. Okay, and what about pharmacotherapy? Perhaps again, looking at it, if it's first construed as a type of OCD, then it's going to be an SSRI used first appropriately. But here it might be that that instead of going with the SSRI, because they take a long time it might be 10, 12 weeks, maybe longer, to get it up to clinical dosage to see if it works. Alpha-2 agonist, clonidine, guanfacine, or 10X, the common name, or Intuniv for the time release, those things tend to work more quickly, and so the experiment can be done within a couple of weeks. So alpha-2 agonist monotherapy, or if they're already getting SSRIs, or if SSRIs are worth a try for whatever reason, then the possibility of augmentation with one of those two medications, or trying it alone. And perhaps neuroleptic monotherapy is another thing drawn from the Tourette's side of the board. Now, we still have the problem with kids who often have a whole range of comorbidity, and this is where the range of skills of a therapist comes in. Everybody can't treat everything and isn't comfortable treating a whole range of associated features, and they are quite a diverse group. Sometimes then referrals out is useful, but most important is to decide, is it the tic? I find that since we've become sort of popular with the Tourette's community and the local Tourette's group, we often, when people come in for treatment of tics, we find out that more disruptive to their life are the associated features, and they may go out, as we'll see later, with the strategy of observing the tics to see if it's getting worse, getting better. Maybe maturation is going to take care of it. But the other things that are more disruptive, the the oppositionality, the disruption within the classroom because of anger outbursts or something, the kids teasing them and they have no control, seem to have no control over their emotional reactions. So emotional dysregulation, oppositionality and aggression. If they're hitting their parents or doing damage to themselves or to other people, these are problems. So many of these other things may even uh, uh, warrant a reconsideration of what do we really want to go at here. We're dealing with a nervous system that's not complete. It's a work in progress. A child at 12 is going to be very different as when they're 14. Lots of different cells, very few of them remaining from when they were 12 in their body. And emotionally, many more connections. And we usually call it they're becoming more mature, more grown up. And that means that something is happening within their nervous system. It's not all social. Some of it is neurological, the changes that are occurring, the natural changes, the greater inhibitory control. We think of young people as having some more self-control problems. When we see it in an 18-year-old, or we might think of them as as having more significant psychological problems. When it's a kid, they have a tantrum at the checkout line at the supermarket. We think, oh, just a kid, a bit out of control, but what are you going to do? Maybe in a couple of years it'll be okay, or needs a little more parenting to help with that. So both social and maturational processes will take care of that. But anyway, that's we're looking at nervous systems again to a shorthand way of thinking about them, that have the sort of hair trigger nervous system, easy to arouse and hard to settle. Easy to arouse, hard to settle. Even tics, easy, exciting that, and hard to settle it down without doing certain things that have problems in their own right. The same thing with emotions, the outbursts, the meltdowns, about with the sensory things, noises, sounds, fabrics, labels that other kids don't even notice. They're like intolerable. And being overly frightened about different things, or scared or stressed out by crowds and things of that sort. These are signs of a nervous system, easy to arouse, hard to settle. So we might be dealing then with a lack of inhibitory control across the board, perhaps because of nervous system characteristics, and in part because perhaps of incomplete or inadequate socialization. But I'm going to emphasize the former as opposed to the latter, so we don't blame families for this. Families know that they can have a number of kids and only one of them is this kid, the Tourettic OCD kind of kid. So what are the implications for treatment? Well, the use of, I mentioned, I called it here habit reversal, but it's really substitution strategies of various sorts. We have kids that have doing a variety of things that are harmful to themselves, and so rather than just tell them to stop it, don't do it. That's a response prevention. To say do something else instead. If you feel like chewing on your fingernails and you've bitten down, it's bloody and so forth, perhaps then have something in your mouth, Tic Tacs or something that will divert that away, or reward based for keeping their hands away from their face, away from their mouth. Relaxation training, because there is a phenomenon where increased arousal can set the threshold lower for tics and tic-like occurrences. Exposure and response prevention are important for these kids. Unlike comprehensive behavioral intervention with tics, which says try to keep the kid removed from situations that provoke that tic, here intentionally provoking the tic, but teaching control in the presence of the provocative cues. So if a person, for example, can't help but line up or feels that they must line up their pencils and pens and make everything square to the table before they start their homework, and it's very hard because they keep doing it and things are out of place, so they use a pencil. Now they feel like it's moved to a different spot. Well, here's a situation where exposure to anomalies, exposure to things being out of place is important, because you can't always control the world. You have to teach the child to live in that world. And so exposure response prevention from the OCD toolbox becomes part of the armamentarium for the Tourettic kids, Tourettic OCD kids. Tick shaping, in other words, it's familiar to most, where if you can't stop it's hard to completely stop the tick, to make it uh, uh, to help it morph into something that's less disruptive, less socially unacceptable. So a throat clearing, which may substitute for a profane word or something. So the idea that or touching parts of the body that are misconstrued as sexual actions can be, putting hands on the belt or on the hips, and so these are tick shaping in the hopes of a step before eliminating the need to have any kind of response entirely. So here we're talking about, again, is it a tick? Is it a compulsion? A mixture. So I call it tick shaping, but it's really whatever we want to call it. Some people have made up names for these combined forms. And CBIT, which means HRT and a little bit of functional intervention, meaning, don't reward them for having a tick, don't let them get out of mowing the lawn, but also don't give them too much attention, and keep them away from situations that provoke it. Again, that may be useful in some cases, but here combined in where exposure and response prevention seems to be a more effective and more comprehensive approach. So what are some other implications of a Tourettic OCD treatment besides the toolbox that now has tools that weren't there before? And the answer will be for clinical decision making. These all are coming up next, by the way, in the next portion. Different decision making along the way than we might otherwise do. Having a strategy for handling the alphabet soup kids. Communicating with parents and their families, how to talk with these kids that often feel very damaged. Parents thinking, this is overwhelming, there's too much, I can't do all of this with this one child. Teachers who say, this one kid makes me wish I didn't go into teaching. The rest of the class is fine. They're not bad kid, they just are disruptive and stirring up everybody else. And finally, the developmental forms of OCD and Tourette's. The idea that one can morph into another. The alphabet soup first. Don't let them see you sweat. In other words, okay, we're gonna get a kid who comes in. They might be all over the office, turning the office upside down, constantly in action, behaving in ways that seem a bit out of control to us, and certainly against the rules of the way people usually behave in our own offices. So we have to be kind of cool about that. Parents are often much more upset. Don't touch that, stay away, that's the doctor's property, don't touch it. And to begin to model not allowing intolerable things, but allowing for children who are in motion, who don't obey all the proper rules that we might think are appropriate. Now I'm going to tell you about Josh. Josh, an actual kid, came to me at age 11 and in the past, by the time I met Josh, he had all of these different diagnoses. Not currently, but he saw many different professionals, and he clearly had some OCD kind of characteristics and tics, very obviously so. We'll look at him a little later and understand that. ADHD, like lots of it. Oppositional defiant. He was, in the minds of some adults, a bad kid. Hard to, just didn't listen. Too insistent. If he had a point, he wouldn't give it up until everybody attended to it and he felt satisfied that they understood and listened carefully. He had some learning disabilities. You'll see that his writing was not commensurate with what was appropriate for a sixth grader, and so he was diagnosed with a learning disability, that one plus others. He was depressed because his life was going down the tubes and there was no solution. He was no longer welcome in his school. That's when I met him, when he was actually being asked whether there might be a more restrictive environment for his education that would be appropriate, more appropriate than a public school. He had a skin picking problem where he picked at his legs. It started with mosquito bites, but it continued through the winter because he never let them heal. He had it on his arms and on his neck, his back to some extent, because he kept picking at scabs, never healed, and occasionally would get infections and had to see the dermatologist as well. Generalized anxiety disorder. He was a worrier, smart kid, so he's thinking about all the possibilities. What if this happens? What if that happens? What if the kids don't like me? What if they start teasing me? What if they know to call me? What if they figure out to call me that name that they call me that I can't stand? Makes me so angry I get out of control and start hitting them. We'll hear about that name too. And he also had school refusal and some social phobia. That's SP there is different from the other SP. Social phobia because he didn't like to meet new kids because, well, he obviously acted different from them and kids notice. So and they can be pretty cruel. Okay, so you see the writing for a sixth grader. This was something he wrote, but I'm going to make another point here. The other point that I've emphasized in some of the writing was that these kids, if we can help them pass these rough developmental stages into their adulthood by lowering the problems they're having, helping their adaptability and their adjustment to situations that are required, we might have some pretty amazing kids here. I'm old enough and been in this position for long enough to have seen kids grow up. I have one gal who was first taught me a lot about. She was the one I think I noticed the connection very clearly. And I remember her practicing going up and down steps without the usual kinds of fancy things she did, and made her very difficult. Couldn't get in school. She had to go up and down the steps with a teacher helping her, being very patient, often arrived at the next class late. So she's now, by the way, running. She went to school as a veterinarian, but she's in Africa running a team that are doing research on shared animal-human viruses, and she's the head of the team. She went through veterinary school on a full scholarship, no, undergraduate full scholarship, University of Maryland, veterinary school, completed it with honors and went on to be a fine veterinarian, but then into the research realm. So what I'm saying is that these kids' problems are no indication that they don't have potential to become wonderful and adjusted and really quite impressive kids. And I'm going to read you this poem because Josh, underneath all of those problems, was a very special kid, is a very special kid. Although I lost track of him, he was on a very good path, and we're hoping for the best from him. But you can see it. One of Josh's most notable tics was a howl, a wolf-like howl, and kids would call him Wolfie, and that would get him angry and it'd get out of control. But he wrote a poem, The Wolf, and this is, I'm going to read it to you because it's hard to read from his writing, but it says, "In the woods, the whistle of the birds and the call of the wild, there is only one animal that I understand, the wolf. And friends howl at the moon, telling each other about the magnificent sights in the woods. They howl at the moon, they play, they run. Oh, in the woods, there's only one animal I understand. When the rain falls and the thunder claps, my friends hide in a cave and howl at the moon all night. And when it stops, they come out to play in the morning light. Oh, in the woods, there's only one animal I understand. The howl of the wolf at the moon on a cold winter's night. Howl." That is always impressive to me. It's impressive to other people. By the way, I only have permission to use it publicly. I don't have permission to share it in the sense of allowing other people to use it. So please I don't know how you do it or that you would, but I promised Mom that I would only use it to illustrate this point, that underneath, hidden often by the morass of features, comorbid features, diagnostic labels, is a fully functioning, often very impressive individual that is shouldn't be lost in that mess. And so in communicating with families, because everybody feels like they're dealing with a very damaged child. I'm going to look at the time again. 105, so good, so far so good. I tend to say to the kids, call them none of the professional jargon. You have an extra alive kid, supercharged nervous system, extra energy bubbling out, sometimes as sounds, sometimes as emotions, sometimes as thoughts. And there's no mistaking this kid for a bump on the log. This is a very alive kid, extra alive, and a positive thing, I think. I began to talk about the boys originally to say, look, it's like you're driving a Thunderbird and all the other boys are driving Ferrari. I'm sorry, let me start all over. You're driving a Ferrari and all the other kids are driving Toyotas. You have a beautiful machine, the best on the road, actually, but difficult, hard to manage. You could be step on the accelerator in traffic and be in the trunk of the car in front of you before you know it. You could be rounding a curve that you think you're doing 40 and you're doing 80 and hit some gravel and be off into a tree. Later on, my colleague said, what about the girls? And maybe this is a little sexist, but I started to talk to the girls in slightly different ways. Say, you're a thoroughbred. If you what a beautiful creature. Fastest horse on the track, beautiful in motion, hard to take for a quick, an easy walk on the farm. Better to take the old Nelly if you want to get a gentle ride, because that thoroughbred is very twitchy, very hard to manage. One bumblebee comes nearby and you may be often galloping, holding on for dear life. So you have to know how to manage it. Just like you have to know how to manage your car, your Ferrari, you have to know how to manage your beautiful creature, the thoroughbred that you are. And this is a different way of talking about kids. And even parents can smile as we talk about it that way. The kids, you can see they sit up a little better. I remember one kid said, there were some car magazines outside. Any of them that have stories about Ferraris? I said, no, but you'll be able to find them online. And so there was definitely connecting with the idea that what you're seeing is not necessarily all bad. It just is there's some good there, and a lot of good managed well. I saw a description, I guess, on a Tourette website the other day where a mom described her child as bubbling, sparkly, and quirky, and I like that. I think of quirky as interesting and offbeat, and bubbling and sparkling. How can you think of that as negative? And that was a kid with Tourette disorder. So I like that. It was finding positive ways of describing things that we all see and are aware of, but without the heavy pathological language that's often associated with it. So what about the decision making? About educating the patient, family, and other professionals that we're going to not jump in and try to make this kid over, because maturation may very well take care of a lot of things we're wanting. The nervous system becoming more comfortable with inhibition. The inhibitory mechanisms developing, maybe more slowly, maybe less reliably, but developing nonetheless. So we're going to choose our therapy targets wisely. There's too many things to work on. So we're just going to choose the ones that are most disruptive, that cause the greatest impediments to things that need to be done: to go to school, to make friends, to get to sleep, to be a good family member, or as good as possible. The goal is acceptable adjustment, not perfection. We're not going to try to make this kid over. We can't. And if we try to make him just like the well-behaved kids, we might be given too much medication or too much therapeutic attention. That means we have to encourage tolerance, and that's part of the education among caregivers, that they are quirky, they are a bit of a handful, that you need support and you need to help, and we'll help you wherever possible. When you find something that is too much, over the top, that needs attention, we'll add it to the list of things to work on, but not everything. Let's be judicious about that. Push for accommodations where necessary within the school system, or accommodations otherwise, where we won't go to that restaurant because grandma thinks it's too quiet and this child's noise embarrasses her, so we'll go to noisier places. So there can be accommodations all over the board, with the family, with the schools, with other settings, with the Taekwondo class and so forth. And attending to the self-esteem of the patient. These are kids who can feel hopeless. They can, if they everybody considers them bad, maybe that's the only mark they have on the world, is to, if they can only be bad, maybe they can be really bad. So now we're trying to tell them, no, we're going to look for the other things that you do well, even better than others, and we're going to take pride in those and try to emphasize those. So what about development here? And this is an idea that that one thing can morph into another. This is the idea that out of a Tourettic background, a Tourettic nervous system, which I've already described to you, can emerge some standard classic OCD. So let's take the stages as I see them and as I saw them with some of the children that I watched them over time. A child is born with a Tourettic nervous system, easy to rouse, hard to settle, that hair-triggered nervous system. They may, in fact, begin to show tics or associated secondary features, but not necessarily. Remember, tics may not be part of the picture, but they may start to look like the beginnings of the alphabet soup kids. They may begin to emerge some Tourettic OCD features, the demanding, I have to do things just this way. I have to have my animals lined up. My shoes have to be lined up before I go to sleep. Every door has to be closed. Every drawer has to be closed tightly. All of these things are the examples of the Tourettic OCD features. There's no real fear or anxiety. It just is a feeling that unless it's done, I feel uncomfortable and I won't be able to do things that are comfortably. Then now here's where maturation intervenes, because kids have an explosion of their cognitive abilities at 7, 8, 9. We can see that with our own children. All of a sudden they're asking ideas about death and infinity and the Big Bang and who knows what. And we went, where did he get this kind of thing? Where did she get it? And so we're starting to see, and also they're looking at their own behavior and wondering, why am I doing this? And now they begin to attach meaning to it. Like, the reason I line up these things, or the reason I do this, or the reason I have to touch and touch back is because maybe if I don't, something bad could happen. That's the first sign of a shift over to a cognitive, into the cognitive realm. Something bad might happen. And then more specific, I might lose that big game on Saturday, or I might fail that test, or my friends might not like me, or I may lose my ability to play basketball that I really value. Now it's moving into the OCD realm. Now, because the Tourettic features may actually abate with maturation, you see that we may begin to drop out some of the kinds of more tic-like phenomena, but OCD moves right through puberty very well, thank you, and without any impediment. And now classic OCD can continue with or without the Tourettic features. So the implication here is that if we get these things early, we may prevent the flowering, the development of classic OCD, which can be a life ruiner. And maturation doesn't seem to eliminate or attenuate OCD. It moves on with its own power, cognitive power, and learning abilities that make it lifelong, if not treated well. Now, here's a second point. And I got this point from actually another girl who I won't go into detail because I want to leave 10 minutes for questions and answers, perhaps. But this girl, I expected her to tell me, I'll often ask the question, well, what came first? She had OCD. Her OCD was she was very much didn't want anything to do with Pokemon to be in her head or in her life. And the reason was that she and her girlfriends at 10, 11 loved Pokemon. They had all the cards. They had their favorite creatures. They played Pokemon games, electronic games and other games. And now they were getting to be 12, and the other girls were moving on to other boys and more adolescent kinds of interests, pop music, and this girl began to be less. She began to see that the girls were a bit turning away from her. She wasn't as mature as they were, perhaps, and she thought that it was because she still liked Pokemon while they didn't seem to like Pokemon anymore. So she got rid of all her Pokemon cards. She got rid of her electronic games, wouldn't play with her brother anymore, the game that they enjoyed most. And yet it was still in her head. Now, this is what she told me. She said, no, first what came was OCD. Later, she said, was tics, because when I met her, she would have she was a very, very pretty gal, came from a very attractive family, and she did do she would make these faces and sounds that was so awful looking. She looked possessed. Her father said he didn't like to go anywhere with her anymore. It was so embarrassing. Um, so she told me that only maybe 25%, maybe fewer times, did it have anything to do with Pokemon. It just happened now. So I'm thinking, wow, OCD became a tic? And I'm thinking, well, sure. We had that sometimes throat clearing tics come after a sickness. And the doctor says, he's well, no more, it doesn't have the flu or cold anymore. It probably is just a nervous habit that he's continuing. I remember the kid whose tic was this, and very clearly brushing hair out of his face. Only a year and a half prior, his mom had cut it so short, he had like a brush-like cut. There was no hair in his face, but that was continued, that practice, after the hair was gone as a tic. So what's happening here? Is it possible that in a very small minority that that OCD can turn into a tic? And the idea here is that over-practiced motor habits in a Tourettic nervous system can take on tic-like characteristics. Why not? They have a Tourettic nervous system, the underpinnings. Now they just need an over-practice habit. And so that girl developed the over-practice habits of when she couldn't get a tic, what do they call Pokemon character out of her head. She would, just like us, we don't want to think about something, shake her head and then say, no, and then she'd get more and more violent. And she would do that in a room and in other places eventually as a way of getting Pokemon out of her head partly in the hopes of winning back her friends, but really actually in satisfying tic-like premonitory urges that were occurring. All right, so the compulsion involves tic-like features. There emerges classic Tourette's disorder, sensory motor, with or without, in her case, only part of the time and probably eventually without obsessions present, because even while I knew her, she seemed to, the proportion where she was getting comfortable with Pokemon things again, but she was still doing that behavior. So it looked like it had a separate life of its own. And maturation may play a larger role in limiting the duration of symptoms in this subtype. So for a lot of kids and families, I'll say to them, let's not go at these tics right now. Our tools are not that wonderful. And your child is a little young and it's a self-control strategy. Little kids are hard. They're not as easy to get to control themselves when they're by themselves. So let's go. There are business things we can do, but we don't necessarily go after the tic. And I have a 5-point scale. I didn't put it here, but where if it's two reasons to definitely go at it. If it's hurting the child medically, if they're pushing in their eyeball or damaging or overdeveloping a muscle that is now causing some postural problems or any medical issues, or if it's interfering with sleeping or doing their homework or eating. All right, that's 5 and 4. Medical problems, interference with then we go at them. Those are in the red zone. In the middle is I'm not so sure. It's bothering a lot of people. It's a problem, but he's able to do his homework, able to get to sleep, and not hurting him physically. So we'll keep an eye on that. We can decide to jump in at any point. 2 and 1, we're going to wait and watch for 3 months. We're just going to observe it and notice whether it's losing its power over the 3 months, whether it's staying the same or getting worse. If it's getting worse or seems to be more and more persistent, we will then reconsider and maybe go after that tic. But otherwise, let maturation take it. We have other things to do. So let's put that on the back burner as long as the family agrees that that yes, we wish it weren't there. The kid says, I don't like doing this, but it's not a big deal. It's not interfering with life. There are other bigger issues. Then we go after those. Now, finally, what are the advantages of having this integration of Tourette's and OCD? Well, one, it describes an interaction between two things that if you work in either camp, mostly you're going to see the other because they are comorbid and they are related in ways that are not entirely clarified at this point scientifically. It emphasized a functional relationship between the kind of experiences a person has and the behaviors we see. And before, when I read the list of 10, is it a compulsion or is it a tic? There, it says that that some of these problematic repetitive relationships can only be thought of as understood by knowing the phenomenological experience of those individuals. Are they thinking of great harm coming to them in elaborated obsessions, or is it simply a feeling that they do this or else they're going to be uncomfortable? Finally, it guides the process of deriving treatment components from the OCD and Tourette's literature for a significant subset. So our staff, the 18 therapists, they easily combine these two, the ones who work with the kids and some adults as well, will seamlessly blend treatment using both the OCD tools and also the Tourette's tools merged into one unified, focused, strategic therapeutic approach. And finally, we just left, it guides treatment conceptualization. What am I going at here? What's most important? And helping with decisions along the way, particularly when there's a great deal to do, as in the alphabet soup kids. Disadvantages, this is one I heard, oh no, another diagnosis. No, it's not. It's a conceptual framework. It's just a heuristic, a tool to think about a complicated and frequently occurring type of childhood experience that often is presents to therapists for help. A second problem, there is a pecking order, and particularly within the anxiety OCD community, there's a bit more stigma attached to the Tourette's card. Not always, and it's not universal, and it may be changing, but people that I talk about Tourettic OCD and they've never had a tic, I don't even mention that it's Tourettic OCD. I say TOCD. Later on, we'll talk about the T. And I'll if they don't have a tic, I'll just say no. It's not going to be if they're unfamiliar with Tourette's and they've only seen the worst example, the problems of obscenities and other things that are intolerable socially or very difficult socially. Then I'll say we're not talking about that. We're talking about an underlying nervous system, a type of nervous system that is, kind of produces a lot of tension, distress, and is relieved often by motions, actions of the individual. And possible resistance from medical and other professionals, that disappeared. There was a lot early on when first talked about that. Not a lot, actually, because I had already been part of the board of the local Tourette medical society, and so I knew most of the folks. But now we get most of our referrals from Children's Hospital, from Georgetown, from Johns Hopkins, since they closed down their movement disorders program about a year ago. We have a lot more people coming. So quite contrary to the idea of medical professionals objecting to this or other professionals, very little objection because people use it where they see it useful, or reject it, I suppose, if they don't. But just the opposite is I still get many those articles out there are still floating around, and I get emails and calls from all over the world asking about it. So it does seem to fit some need that still exists out there. And that's the end. And we have just a few minutes, and I'm not sure what to do next in order to in order to get back to a live sort of thing. So I'm just going to close down my all right.
Dr.
Let me see.
Mansueto,
Yeah.
so I collected the questions. We had a lot of great questions rolling in, both from a
Yeah.
practitioner perspective, but also from a family perspective, an
Yes.
individual perspective. So what I'm going to do is I'm just going to read you a couple, like we'll probably only have time
Very
to
good.
get to 2 or 3 questions, but I
Okay.
collected them all. So anyone, please, any question we don't get to today, feel free to reach out to us directly at support@tourette.org. Shoot us an email. And we also collected the questions so that way there can be follow-up afterwards as well.
Hmm.
So I will just ask a couple of questions here for
Sure.
the next couple of minutes. So someone asked, can you talk a bit about sleep disturbance in relation to this TOCD presentation, such
Sure.
as restlessness,
Yeah.
fearful nightmares, sleep onset difficulty, etc.?
Right. Well, sleep is a realm that's extraordinarily important, and we there's as psychologists we do a sleep hygiene approach. There are certain things that interfere with the onset of sleep rhythms, and then eventually adaptive sleep, and there are things that interfere with it. So we usually do a sleep hygiene approach. However, with this population, we have to be more attentive to the possibility that some of the features that we've talked about here are interfering, like the idea of getting the pillow just right, or getting taps on the headboard just right, or having, so again, there is ordinary sleep, don't drink Coke and things with caffeine in it early, and don't play exciting video games in bed, and don't if you're not tired, we have all of the usual sleep hygiene approaches as part of our way of addressing sleep. But with this population, we're more likely to do more careful Sherlock Holmesian analysis to see if there are tick or tick-like phenomena that are causing it, or nervous system things, over aroused nervous system, or worries about getting to sleep. So again, it's really important to do what's called a functional analysis to determine what are the proper targets for therapy in cases of sleep disturbance. So that's incomplete, but a start on answering that, I think. Another one?
Okay, great. Another question we had is Tourettic OCD typically diagnosed by a neurologist or psychiatrist?
It's not a diagnosis, and a lot of people haven't heard of it because it isn't in the books. In Washington area, everybody's heard of it because I'm here, and we've been around for 30 something years and working with Tourette's community, with the children's hospitals, and with the Tourette's Association, and I'm on the OCD thing, Mid-Atlantic and national. So we're established, and people come to us, and people who read the articles, as I said, call me up from all over, and I basically tell them, don't come from Japan or even Pennsylvania. Find someone who works with both OCD and Tourette disorder, tics, and if you can, and let them read that article, the third article on there, which, by the way, can be found a couple of ways. One easy way, the third one, if you haven't seen that, that's the best one. It's written for families and sufferers, not for professionals specifically, but it has information for sufferers, much more widespread than the others. Go to the IOCDF, the International OCD Foundation, its website, iocdf.org. Put in the search bar Tourette, and what'll pop up should be first article that pops up, or maybe it'll go to Ask the Experts, and maybe that's where you put in the search bar. I don't remember exactly, but it's easy to find. Everybody I said to go there seems to have found it easily. So search bar Tourette, the Ask the Experts section. It's called something like the name of this one. It's on the slide. It was re-examining the OCD and Tourette's, re-examining the relationship, I think it's called. So that's the best thing to do. Neurologists, they're mainly ruling out, some other types of things that can cause tics. They don't necessarily, if anything, they'll mainly handle it with medication. If it's more OCD, it's likely that a psychiatrist will and rarely is a psychiatrist able to do CBT, so eventually you wind up perhaps in the hands of a psychologist or a social worker, counselor that is trained in that. It's not so easy, but Find a Therapist is available on IOCDF. There's a Find a Therapist thing, and they'll say whether they work with Tourette's. If you go to the Tourette, I don't know if Tourette's has that same Find a Therapist thing, but so does the ABCT.org, Association for Behavioral and Cognitive Therapies.org. Find a Therapist, put in Tourette's, put in, or tics, put in either one, and OCD, and you'll get a list of therapists who say that they are comfortable treating those things. So that's the way I would go about it. If you go to a neurologist is rarely going to treat the whole thing, except they might prescribe medication. It's useful to have someone who appreciates the learning-based therapy and knows how to do it, and also understands the importance at times of medication to augment that. That's what you look for, and good luck finding it. I mean, some communities it's easier than others. We're rich with wonderful people around the Washington area, but everybody isn't quite so lucky to have so many great psychiatrists, neurologists, psychologists. It's, you know, so it demands a search, and sometimes you have to make do with what you have, because you just don't have the properly trained individual who covers the whole ballpark. We're stepping into two different arenas, and so to be trained in one it takes quite a bit, and to have the experience to treat it. Now we're talking about being trained in two. There's going to be a smaller number of persons who are available. Okay, there might be, I can stay, but if some people have to drop out, I understand that, or if I have to get out of this room, so you have availability for the next person, but
Yeah,
I'm willing to take a
unfortunately, we have to wrap it up just because we have to get it prepared for the next session. But
Okay.
everyone, I know that we didn't even get to nearly touch all the questions that we had. So please feel free to reach out to us, like I said, at support@tourette.org. And we also have collected the questions, so we can also do some follow-up. Thank you so much again, Dr. Mansueto, for joining us today. Seems like it was a beneficial topic for so many. And also thank you again to all of our sponsors for making this possible. Everyone, you will receive a link to the recording within 24 to 48 hours from GoToWebinar, and we will also be uploading the presentation onto our TAA YouTube channel, so you will have ways to access this. So thank you all so much, and everyone have a fantastic day.
Thank you. Nice to be here. Bye-bye now.